Today we'll be talking about the approach to abdominal pain in the pediatric ED. I'm Iman Lubani, one of the pediatric emergency physicians here at London Health Sciences Centre in London, Ontario, and an assistant professor at Western University. I'm also the undergraduate medical education coordinator for the Pediatric Emergency Department in London, Ontario. So today our objectives are to understand the epidemiology and pathophysiology of abdominal pain in children, to develop an approach to the history in a child with abdominal pain, to develop an approach to the physical exam in the child with abdominal pain, to review the differential diagnosis of pediatric abdominal pain, to identify red flags that point to more serious underlying etiology of abdominal pain, and to develop an approach to the management of pediatric abdominal pain. So why does pediatric abdominal pain matter? About 5 to 10% of all ED visits by children are for abdominal pain, so that's quite a large burden. In the United States, about 38% of school-aged children complain of abdominal pain weekly, and almost a quarter of those who complain of abdominal pain weekly have had the pain for more than 8 weeks. Most cases of abdominal pain in children are self-limited and due to benign underlying causes, but about 5 to 10% of children with abdominal pain have some underlying organic disease, and we need to tease out which of the children that we're seeing comprise the 5 to 10% with serious underlying disease that we have to investigate further, and which comprise the 90 to 95% with the more benign underlying self-limited causes. So what is the pathophysiology of abdominal pain? Abdominal pain is caused by the stimulation of the nociceptive receptors and afferent sympathetic stretch receptors. What does that mean for us, practically speaking? So when we're classifying abdominal pain, there are three groups or three types of abdominal pain. Visceral pain caused by excessive contraction or tension of the small or large bowel, solid organ capsules or mesentery. And this is usually a diffuse dull pain when the child or when the patient describes it. Parietal or somatic pain is caused by inflammation of the contiguous parietal peritoneum. This is often characterized as a sharp and localized pain. So think of your appendicitis, for example. Referred pain is pain that's felt in remote areas that are supplied by the same dermatome as the diseased organ. So for example, that child with pneumonia who presents with upper quadrant pain because of the shared T9 dermatome between the lower, the bases of the lungs and the abdomen. How do we approach the history in abdominal pain? So a mnemonic that has helped me out in the past is the OPQRSTUV. So this is a long mnemonic, but when I keep it in mind, it helps me not to miss important questions. O, onset. When did the pain start? How long has it been going on? P, pain location. Where is the pain located? Q, quality of pain. Now this is looking at that sharp, dull, diffuse, localized. R, radiation. Does the pain radiate anywhere, or do you feel the pain somewhere else? S, severity. So we use a scale of 1 to 10, 1 being the least pain and 10 being the hugest amount of pain you've ever had. T, timing. When does the pain occur? How often? U, under what circumstances? So, for example, does it follow eating? Is it only when you're walking? What brings it about? V, vocation, and in our case, of course, we're talking about children. So how is it affecting functioning? How is it affecting school attendance or daycare attendance? Associated symptoms are also important to tease out on history, things like fever, vomiting, diarrhea, hematuria, dysuria, rashes, joint pains, oral ulcers, cough, shortness of breath. All of these associated symptoms are important to tease out. On history, we're also looking at the child's hydration status. What is their urine output? So for babies or children in diapers, I ask about how many diapers are being changed every day. How many pee diapers does the baby have a day? Fluid intake, how much are they drinking? Stooling history is also important. The frequency and consistency of stools. Are we talking about loose stools? Are we talking about hard stools? Do stools clog the toilet? Is there soiling of the underwear? Past medical history, of course, is important. Past surgical history is important because, of course, if there's been previous abdominal surgery, there's a risk of adhesions and obstruction. Family history, so things like inflammatory bowel disease, celiac disease, renal disease. And then, of course, a gynecological and sexual history, especially in the older child and the adolescent. So are they sexually active? Do they use some form of birth control or some form of protection? Because, of course, abdominal pain could be due to gynecological or obstetrical causes. So an ectopic pregnancy or in terms of gynecologic stuff, pulmonary or pelvic inflammatory disease and other gynecological causes. Approach to the physical exam in abdominal pain. So here, of course, like any other physical exam, we want to first make sure we have stable ABCs, the airway, breathing, and circulation. So you want to make sure that the patient is safe and stable before you continue on. Vitals, we're looking at temperature, so is there a fever or not, heart rate, blood pressure, oxygen saturation, and respiratory rate. Hydration status is important to assess. So looking for dry mucous membranes, for example, to tell you they may be dehydrated. Tears, if they're crying and have a lot of tears, then they're not severely dehydrated. Urine output, so do they have a full wet diaper on when you examine them? The abdominal exam as well, of course, is important. We observe, is there distension of the abdomen? Are there any obvious masses that are visible? Is there any bruising on the abdomen? We percuss. Is there abdominal fluid, so ascites, that might lead you to hepatic cause of this abdominal pain? Is there rebound tenderness? Palpate, and we palpate in all four quadrants to see where there is any tenderness. And we're looking for location of pain, and of course we're also looking for hepatomegaly or splenomegaly. In assessing hepatomegaly, you want to start in the right lower quadrant and work your way up till you get the liver edge. And in assessing splenomegaly, you also start in the right lower quadrant, and then you're palpating diagonally up towards the left upper quadrant because the spleen enlarges in that direction. Also on the physical exam, you want to look in the oral cavity. Are there any oral ulcers that might lead you to think of something like IBD? You want to look at the skin. Are there any rashes that may lead you to something like HSP, IBD, or systemic lupus? You want to do a respiratory exam. Again, this is looking for the referred causes of pain, like pneumonia, for example. Are there any crackles in the lungs? MSK, you're looking for joint redness or swelling or joint pain. And again, these may be signs of HSP, IBD, or lupus. A rectal exam can be performed in specific cases. For example, if you've got a history of bloody stools, fecal impaction, or suspected Hirschsprungs. Otherwise, in kids, we typically avoid putting a finger in the rectum because it can be traumatizing. A GU exam is also quite important. In boys with abdominal pain, we will do a testicular exam. And in females of reproductive age who are sexually active or complaining of any vaginal symptoms, we'd also do a vaginal exam, especially for suspecting PID. The differential diagnosis of abdominal pain is wide, and it is an age-based differential often. You can break it up into the emergent or urgent causes and into the more common or generally benign causes. We'll review the more emergent causes by age group, and of course it's worthwhile looking at the more common causes as well. In the neonate, you're thinking about necrotizing enterocolitis, malrotation with midgut volvulus. Could this be Hirschsprung's disease with toxic megacolon? Pyloric stenosis presents at this age, typically with vomiting as opposed to abdominal pain, but it's still on the list. You can have testicular torsion in the neonate, and you can have obstruction due to atresia. Infants can present with intussusception, incarcerated hernias, so always look at the inguinal area. Hirschsprung's disease, again with toxic megacolon, Meckel's diverticulitis, although this is often a painless rectal bleed, and hemolytic uremic syndrome. Older kids and toddlers, appendicitis, Meckel's, testicular or ovarian torsion, intussusception, and hemolytic uremic syndrome again. And then, of course, in the adolescents, appendicitis, cholecystitis, cholangitis, testicular or ovarian torsion, ectopic pregnancy, renal colic or renal stones. And of course, these are not exhaustive lists. These are just to give you an idea, and you kind of have to follow your history and physical to know exactly where you're headed with this patient. I like to think of the differential diagnosis of abdominal pain in the child in a physical way, or in a very visual kind of way. And I like to divide the abdomen into its quadrants or sections. In the right upper quadrant, I've got the liver and I've got the gallbladder. So I think of hepatic causes, so hepatitis, cholecystitis, and gallbladder causes, cholecystitis, choledocholitis. Also in the right upper quadrant or flank area, I've got the right kidney. So I think of kidney stones, for example, pyelonephritis. Those can present with pain there. In the right lower quadrant, you've got your appendix, so appendicitis. You've also got your ovaries, so ectopic pregnancy. Intussusception can also show up with that, or a ruptured ovarian cyst. In the left upper quadrant, you have your spleen. And of course, you also have your heart that could refer pain there. So cardiac etiologies, ruptured spleen. You also, in the left upper quadrant, have your left kidney. So the same as on the right, you're thinking about the renal pathologies. In the left lower quadrant, usually you're looking at things like constipation, possibly hernia, hemolytic uremic syndrome, IBD, Hirschsprung's disease. And of course, also your gynecologic causes that we discuss on the right side. Periumbilical, you're thinking about early appendicitis, functional abdominal pain, things like mesenteric adenitis, and of course, not to forget things like diabetic ketoacidosis, which can also present with abdominal pain. So having kind of this visual representation will help you a little bit when you're trying to develop and flesh out a differential diagnosis for the child presenting with abdominal pain. What are red flags in pediatric abdominal pain? If you see a child with abdominal distension, you have to worry that you're missing something underlying that is serious. Abdominal pain that onset before the onset of vomiting is also worrisome for a serious pathology. Bilious emesis, of course, is very worrisome. Bloody emesis, bloody diarrhea or blood in the stool. Fever after onset of the abdominal pain may be indicative of something more serious like appendicitis. And weight loss, which might make you think of something more sinister underlying like inflammatory bowel disease. So in terms of the management of abdominal pain, we will be dividing abdominal pain into acute and chronic abdominal pain because the management can differ somewhat. So acute abdominal pain, which is abdominal pain of less than 2 weeks duration, the goal is to identify any serious or life-threatening causes of acute abdominal pain, so things like appendicitis, intussusception, etc. We're looking for the presence of red flag symptoms or signs, the ones that we just reviewed earlier in the past slide. And these should prompt further investigation and a more thorough workup. We're also going to want to ensure adequate hydration and fluid intake. And we're going to provide symptomatic treatment for common non-life-threatening conditions, so things like constipation, functional abdominal pain. We want to improve patient comfort by doing this, and we also want to reduce the risk of representation to the emergency department, which can happen. So in terms of the management of acute abdominal pain, we're looking at the history to prompt us to look for more serious causes of the abdominal pain, things like acute severe pain that is more localized, pain that's increasing in intensity, pain that precedes vomiting, bilious vomiting, hematochezia, and a history of previous abdominal surgery, so things that we reviewed earlier in the red flags. On history, things that are telling you this is less likely to be surgical are midline or generalized abdominal pain, stable pain intensity, something that's not increasing a great deal, vomiting that's absent or that comes before the pain onset, and a longer duration of the pain. In terms of the physical examination, things that should prompt you to look for more serious or surgical underlying causes of the abdominal pain are an ill-appearing child, a child who's lethargic, a child with abdominal distension, absent or high-pitched bowel sounds, localized tenderness, and peritoneal signs like rebound tenderness, rigidity, or guarding. So all of these are making you think that this might be a sicker child or a child with a surgical abdomen. On physical exam, things that tell you this is less likely to be surgical, less likely to be a worrisome cause. Non-distended, normal bowel sounds, diffuse tenderness that's not really localized anywhere. And of course, this is usually more of a mild tenderness. We're not talking about the diffuse tenderness of peritonitis or of a perforated appendix, for example. No rigidity or rebound tenderness is also more reassuring. Initial evaluations that we would want to complete if we have a more serious appearing cause or things that are raising red flags on history or physical examination, we'd want to do labs, so a CBC, lights, liver enzymes, lipase. Amylase is not something we typically use in pancreatitis. It's something we actually use more commonly if we're looking for peritonitis. So amylase is not one I would use, though it's listed here. And we do urinalysis, and of course in teenagers or adolescents, we want to do pregnancy tests in females to make sure that we're not missing something urologic or GU or obstetrical. Imaging, such as an abdominal series, so 3 views of the abdomen, looking for abdominal distension, or looking for signs of obstruction essentially, or an abdominal ultrasound. When you're thinking about appendicitis, intussusception, pyloric stenosis, you need an abdo ultrasound to rule that out. X-ray will not. How about chronic abdominal pain? So abdominal pain that lasts more than 2 weeks. This type of pain is less commonly due to an organic etiology. Most cases do not require referral to gastroenterology, and they'll have you remember that. They really don't enjoy getting these kind of vague referrals for non-concerning chronic abdominal pain. Referral to psychology may actually be indicated in some of these patients with functional abdominal pain that affects the quality of life, because often there are underlying psychological factors that contribute to this pain. And make sure you look for red flags that may prompt you to investigate further or to refer on to GI. So things like anemia, unintentional weight loss, hematochezia, or abnormal findings on physical exam. So here are our references. It's been fun reviewing abdominal pain in the pediatric patient with all of you. Best of luck to you, and hope to see you soon in the pediatric emergency department.